Good evening, consultants, fellows on the call. Good evening, colleagues. You are welcome once again to today's meeting. Today, we are fortunate to have one of our colleagues take us through the 2024 years guidelines on peripheral arterial disease and aortic diseases. We hope as much as possible he will be able to take us through and give us enough pointers that will help us, especially the candidates, towards our preparation for the exam. Thank you. Dr. Meno, please, your audience.
Thank you very much. Good evening, consultants and colleagues. So we're going to have a presentation C guidelines for management of peripheral arterial and aortic disease, but the focus will be on peripheral arterial diseases for this lecture. So the 2024 guideline is actually an updated and merged versions of the 2017 that looked at the peripheral arterial disease and that of 2014 that looked at the aortic diseases. And its focus is primarily on the atherosclerotic arterial disease, although mention of non-atherosclerotic genetic conditions were also discussed. Okay. And the guideline sought to use a multidisciplinary approach where they recommend that management of peripheral arterial diseases should be done by the cardiologist in the center. However, the role of the vascular surgeons, the radiologists, intensivists, anesthesiologists, nephrologists, nurse, and all these people should also play roles. And the aim is that they want to increase awareness and also manage a condition well through screening and genetic counseling. And then through this, able to do proper assessment to make the diagnosis and use in both invasive and non-invasive ways to achieve their goals. We are aware of traditional risk factors. Some are modifiable, some are not modifiable. And we are also aware of non-traditional risk factors as well. So the traditional risk factors when it comes to atherosclerotic disease, especially with the peripheral artery disease, tobacco is a major risk factor. Then these are modifiable. So tobacco, diabetes, lipids, hypertension are modifiable. Then non-modifiable factors, risk factors like age, gender, sex actually. Then family history, these are not modifiable. Then there are other non-traditional risk factors like overweight, sedentary lifestyle, sleep disorders, stressful lifestyle, alcohol, diet, inflammation. These are more or less these are modifiable. And then we have still non-modifiable, non-traditional risk factors like pregnancy, menopause, social, economic status, environmental pollution, autoimmune diseases, lipoprotein. So all these are risk factors that um, come into play when you are talking about atherosclerotic cardiovascular disease, which includes the peripheral arterial disease as well. So the guidelines recommend that when managing a patient with peripheral arterial disease, you adapt a comprehensive approach as I already mentioned. And then we should also perform thorough clinical, vascular, and cardiovascular risk factor evaluation using labs and other means. And then we should also determine the functional status and overall evaluation of those functional status is also important. And then whether as to whether the patients are symptomatic and not symptomatic too should be considered. And the evaluation with questionnaires are also important, especially the physical and mental well-being is also important, and that's class 2 indication. But at least we know that there should be a comprehensive and then multidisciplinary approach towards the management of and evaluation of peripheral arterial disease. Okay, so in terms of the evaluation, it's recommended that when we are evaluating patients, we take into consideration the clinical signs. Beyond just aiding diagnosis, they may also offer prognostic insights. For example, listening for carotid brew may give you a clue as to the risk of myocardial infarction. And then brachial systolic blood pressure differences may also tell you something about the risk of getting cardiovascular deaths and all. So all these things may also assess. Then you assess lab parameters like the lipo protein A. This one, at least once in a lifetime, it should be done. Fasting sugars, glycated hemoglobin, renal function, full blood count coagulation studies, liver function tests, electrolytes, inflammatory markers should all be assessed. And additional evaluation when needed, like thyroid function test, should also be considered. And then when assessing the functional state, so beyond assessing the clinical state and the risk factors, we also need to know the patients we are managing. So the functional status and the quality of life assessment. So you can do the gold standard is do treadmill testing using standardized criteria. And then in that case, you'll be able to determine the maximum walking distance of somebody. Then at least you document, and when you start treatment, you'll be able to follow the person up. You can also determine the pain-free walking distance. And then you can also determine the 6 minutes walking, 6 minutes walk test. Um, all these will give you an idea about the patient's functional state. Then there's also the short physical performance battery test that can also be used. And you should also not forget to assess the role of this peripheral artery disease on the patients in terms of the psychosocial needs. So things like depression and noise is also very common among such patients. And in that case, you can use other quality of life tools to assess them. So with the after assessing their clinical history, their risk factors, their functional states, you also need to assess the vascular do a vascular examination for them. So ankle brachial index is recommended as both a screening tool and a diagnostic tool. So measurement of ankle brachial index is recommended as a first line non-invasive test for screening and diagnosis of peripheral um, arterial disease. And then using this one, so an ABI of less than 0.9 is diagnostic. However, if you get an ABI of more than 1.4, especially in people you suspect may be having um, um, hardened hardened arteries, such as people with chronic liver, chronic kidney disease, diabetics, and all, when the ABI is more than 1.4, then you can also go ahead to do the tool brachial index. The tool brachial index, when you do that one, and then the value is less than 0.7, then it means that that person that confirms the diagnosis of peripheral vascular disease. So in measuring the ankle brachial index, the formula is to use the higher systolic ankle pressure of the target's leg. So if there's your target, you use this one. Then you divide it by the higher systolic brachial pressure, irrespective of the target's leg. So you can, if your focus is, you can use this one and use either this one or that one, depending on which one is higher. In the same way, if you want, you're focusing on this leg, the left leg, can we use the left leg divided by that of the right or the left, whichever is higher. Okay. But apart from these ones, you can also use the absolute ankle pressure. The absolute ankle pressure, for instance, when it may be less than 50 millimeters of mercury, when there's critical limb ischemia. So critical limb ischemia may lead to ankle pressure less than 30. You can also, or two one less than 30. Ankle pressure less than 50 or two less than 30. You can also use the transcutaneous oxygen partial pressure. The transcutaneous oxygen partial pressure one is less than 30 millimeters of mercury. So that one too is also an indication of critical limb ischemia. Okay. So once you diagnose a patient using the ankle brachial index, you need to also go ahead to identify the level of, you need to identify what is causing the stenosis, what is causing the peripheral artery disease. In that case, you need to use duplex ultrasound to localize the vascular lesion and then also to quantify the extent and severity through velocity studies. So in combination of the ankle brachial index or the toe brachial index, the duplex ultrasound permits determining the hemodynamic relevance of the arterial lesions, and it can also aid with the estimation of the ankle brachial index. And it has sensitivity of 88% and specificity of 95% in determining these things. And then cross-sectional imaging is advisable for revascularization planning. And so ABI and duplex ultrasound are recommended for peripheral artery disease patient follow-up and to also consider it when considering revascularization. Okay. So duplex ultrasound is recommended as the first line imaging method to confirm peripheral artery disease. So after you've screened with ankle brachial index, which and you have a diagnosis, you need to go ahead to do the duplex to also identify the lesions and know where they are and to quantify them. And then beyond the duplex ultrasound, other imaging modalities like CT scan and MRI can also be used as adjuvants in imaging techniques, especially when we are preparing for revascularization as well. So we can, the other imaging modality, digital subtraction angiogram with focus of intervention, then CT tend to have better sensitivity, CT angiogram, better sensitivity. However, it may also overestimate the burden of plaques as well. But MRI gives um, a better imaging modality because it can also be used to estimate tissue assessment. I mean, the viability of tissue and all that can be also gained from MRI studies. Okay, so that is for the peripheral arteries. But in evaluation of the aorta too, um, you have to take into consideration the imaging modality and what you want to what specifically you want to look at. For example, you can use the transthoracic um, echocardiogram or duplex ultrasound, and you can also use transesophageal CT and MRI. All these have the advantage in terms of availability, cost, the time requirements, radiation level, spatial resolution, temporal resolution, nephrotoxicity, accuracy, serial examination, and then whether any serial examination and aortic wall vascularization issues as to whether it's going to give good information, measuring the aortic root assessment and all. So depending on which modality, what you're interested in, you have to choose the appropriate modality. And also as to whether there are contraindications. For example, there are contraindications to contrast. It means that you won't be able to do CT or and then if a woman is pregnant too and all those things, you have to take that into consideration and choose the most appropriate imaging modality. And by recommendation, the transthoracic echocardiogram is recommended as a first-line imaging technique in evaluating thoracic aortic disease. And it is recommended to report aortic diameters using the leading to leading edge convention in end diastole because this has been found to correlate more with CT and MRI findings. But for CT and MRI measurements, it's done with inner to inner edge convention. It is recommended to report aortic diameters from images obtained with double oblique techniques, not axial. And then it's better to use CCD triggered CT. Okay. MRI is recommended for diagnosis and follow-up of thoracic aortic disease, especially when chronic follow-up is required. And it's also said that it's better to use the same imaging modality as follow-up. So if you started with MRI, it's better to follow up with MRI so that there might be consistency in your findings. The aortic roots should be measured using the caps to caps distance. Also, the presence of asymmetry among the stands should be reported. Okay, so these are additional information. Chest X-ray can also be considered when you are suspecting an aortic disease. However, the sensitivity is low, and in the 60s, the specificity is also low. But at times, it can give you additional information concerning other things that may be causing the acute aortic syndrome that you want to investigate. For example, maybe a patient has a pneumothorax, or patient has some pneumonia or other that's causing the chest pain, but not acute aortic dissection or anything. So that for that instance, it's still recommended, but it's a class 2B recommendation. Okay, so we've looked at the goal of the guidelines, and then how we screen for and we screen and diagnose peripheral artery disease using the available imaging modalities. Now let's look at specifically at screening for peripheral arterial disease. Who are we to screen, and what is the guideline saying? So in patients with diabetes or chronic kidney disease and normal resting ankle breaker index, the toe breaker index is recommended because these people have arterial stiffening, and that may have influence on the results. And in patients more than 65 years of age with cardiovascular risk factors, screening for peripheral arterial disease by ABI or TBI should be considered, and there is a class 2A recommendation. In patients with abdominal aortic aneurysm, femoral popliteal aneurysm screening as an additional screening can be done with duplex ultrasound as well, because the femoral popliteal aneurysm may occur when there's abdominal aneurysm, so abdominal aortic aneurysm. So we want to also check that in addition. And in patients greater than 65 years without cardiovascular risk factor, screening for peripheral arterial disease by ABI or TBI may be considered because they don't really have risk factors. Their recommendation is class 2B recommendation. And in patients needing intervention with transfemoral access, screening for iliofemoral artery disease may be considered. And in patients with 2 or more cardiovascular risk factors, screening for carotid stenosis may be considered. So for the carotid stenosis, because in the general population, the prevalence of significant carotid stenosis, that is stenosis more than 70%, the prevalence is generally low, it's less than 3%. So in that case, it won't be reasonable to screen people who are aged routinely. So you just have to individualize the screening. So you choose high risk population to screen. Other than that, there's no point screening. So for those people who have general probability of more than 20% of developing carotid stenosis, those are the people who you choose. And these population include people more than 60 years who have cardiovascular risk factors like hypertension, coronary artery disease, current smoking, or they have first degree relative who has family history of stroke. So those people have increased risk, and these are the risks that are stated. People with hypertension, hemodialysis patients, people with known peripheral artery disease, severe coronary artery disease, before cabbage 2, you have to screen them, or people who have carotid bruit or previous neck irradiation. So these are specific people who have increased risk. So in that case, you can screen them for carotid artery stenosis. Other than that, we don't routinely screen people for carotid artery stenosis because we found that the prevalence in the general population is already low. Okay. For abdominal aortic aneurysm, the recommended screening is with duplex ultrasound, and it's recommended in men more than 65 years with history of smoking to reduce the risk of death from ruptured abdominal aortic aneurysm, and may be considered for men more than 75 years, irrespective of smoking history, or in women aged 75 years who are current smokers, hypertensive, or both as well. So for the general management of the atherosclerotic arterial diseases, these ones, the general management has to do with diet, physical activity, smoking, cessation, then educating, and they're using appropriate risk scoring models. So these modalities together with medications are the mainstay of treatment. So when it comes to managing patients, you need to set targets. You are going to use medication that include beta blockers, ACE, calcium channel blockers, antiplatelets, anticoagulation, statins, anti-lipid lowering medications and all. And then your target is to get systolic blood pressures less than 120 to 129, diastolic blood pressures less than 70 to 79, and reducing the risk of arterial thrombosis, optimal glucose with HbA1c of less than 7 and LDL of less than 1.4. Then in terms of the lifestyle, when you do lifestyle modification beyond the drugs, the lifestyle, it will include educational programs, psychological support, genetic counseling, supervised exercises, and that one, so the goal is to get your BMI to between 20 to 25, the waist circumference less than 94 in men and less than 80 in women. Then low to moderate exercise training, then avoid smoking and all these. These are the targets that you want to achieve. So it is recommended, class one recommendation, that people should stop smoking of any kind, because even marijuana has also been shown to increase premature atherosclerotic cardiovascular risk. So every sort of smoking should be avoided, and not just smoking, but exposure to pollutants and all should also be avoided. And then a healthy diet that is rich in legumes, dietary fibers, nuts, and fruits, vegetables with high flavonoid intake. Essentially, Mediterranean diet is recommended for cardiovascular disease prevention in patients with peripheral arterial disease. Then low to moderate intensity exercises, if tolerated, is also recommended. So for moderate intensity exercise, it's a sort of exercise that can increase your heart rate to um, between 54 to 67 of your maximum heart rate. So calculate a person's maximum heart rate if a person is able to achieve that. And then that means the person is doing moderate intensity exercise. And then for between 60s and 80s, that will be high intensity exercise, able to achieve your heart rate of that one compared to your um, able to achieve about 60 to 80% of your maximum heart rate. So in patients with peripheral arterial disease, individual behavioral counseling is also important to promote healthy diet, smoke cessation, and physical activity. And these are class one recommendations. And it's recommended to promote patients and caregiver education and empowerment through tailored guidance on lifestyle adjustment and the importance of regular physical activity. Okay. So in terms of the smoking, um, for example, e-cigarettes have been suggested, but is regarded as a class 2B indication. However, it's been shown that the people who be on e-cigarettes compared to those who are not e-cigarettes are more likely to quit. So at least it offers some benefits, except that the studies that looked at that didn't also look at the long term. The studies, most of them were follow-up for just about 2 years. So no one knows the long-term effects. Probably that's how come it's class 2B. However, e-cigarettes there's still some level of recommendation for e-cigarettes as well. Okay, so that's in terms of pharmacological management, we've talked about the lifestyle. So in terms of pharmacological management, the principles include antithrombotic therapy, antihypertensives, I mean managing the risk factors, the lipid lowering therapy, and also properly managing diabetes and pre-diabetes diabetic conditions. So for antihypertensives, the the recommended target is to get systolic blood pressure of between 120 to 129 if tolerated. If that is tolerated, in people with unilateral renal artery stenosis, it's also recommended to include an ACE or an ARB in their medications. And in patients with peripheral arterial disease and hypertension, ACE or ARB should be considered as a first-line antihypertensive therapy. And then for the RAS-related hypertension, renal artery stenosis-related hypertension, the combination of ACE, ARB with diuretics and calcium channel blockers should also be considered. But these two are class 2B indications. Okay, so for people who are aged, maybe try and be lenient with your BP targets. If you're able to achieve 140, 90, that is okay compared to the main target of the 120, less than 120, between 120 and 129. That's so instead of that, for the elderly, maybe you may want to go down a little on your target. So for lipid lowering to the targets to get the LDL cholesterol to less than 1.1, and that's a class 1 recommendation. And statins are recommended for all patients with peripheral artery disease, and unless it's contraindicated. And if the target LDL is not achieved on maximally tolerated statins, um, ezetimibe treatment with a PCSK9 inhibitor is also recommended so that you'll be able to achieve that target. And if the target LDL level is not achieved, a combination of statins, ezetimibe is indicated in patients with atherosclerotic peripheral artery disease or aortic disease to achieve the given target values. So these are class 1 indications. So for statin intolerant patients with atherosclerotic cardiovascular disease at high cardiovascular risk who do not achieve their LDL cholesterol goal on ezetimibe, it is recommended to add bempedoic acid, either alone or in combination with the PCSK9 inhibitors. Okay. Statins for the reduction of growth and rupture of abdominal aortic aneurysm should be considered, and that's a class 2A indication. And statins for the reduction of growth and rupture of thoracic aneurysm may be considered, and that's a 2B indication. Okay. Fibrates are not recommended for control of cholesterol. So for diabetes too, the target is to try and get the HbA1c to 7% as much as possible. And that's a class 1 indication. And then in terms of the medications that are recommended, medications that have benefits in terms of the overall cardiovascular risk, such as SGLT2 inhibitors are recommended. And then GLP-1 receptor antagonists have also been proven to have benefits. And as much as possible, to try and avoid hypoglycemia. That's a class 1 indication. Okay. So what we've discussed so far is like the general thing that applies to all atherosclerotic cardiovascular disease. We want to focus a little more on peripheral artery disease. So for peripheral artery disease, we are looking at an arteriomatous lower extremity peripheral artery disease. And it's a chronic disease with different clinical manifestations. So peripheral artery disease may be symptomatic or asymptomatic and may or may not be associated with limb wounds. So wound healing becomes a problem and the risk of amputation may be affected by concomitant presence of peripheral artery disease and when there's diabetes or infection. Therefore, amputation risk assessment should be systematically performed using wound ischemia and foot inspection classification as well. Okay. So once you see a peripheral artery disease, then you should also have it in mind that the person you are seeing has an increased risk of other major cardiovascular risk as well. So, so cardiovascular risk generally increase to about 4 to 5 times as in those people with peripheral artery disease compared to those people without. And so anytime you are seeing such patients, it means that you have to have it at the back of your mind that these people are at increased risk. And so we want to then go on and then risk assess them properly and then manage them appropriately. Okay. So the peripheral artery disease can be classified based on the fact that it may be symptomatic or asymptomatic. So there are two ways of classifying it. You can use the Rutherford classification or the Fontaine classification. So for the asymptomatic peripheral artery disease, you can also for when it comes to the Rutherford, they belong to category 0, so they're asymptomatic. And then for those that are symptomatic, you classify them based on whether they are mild, there's mild or moderate claudication or severe claudication. That one, mild, moderate, severe claudication. So you get three ones. And then there are people with chronic limb threatening ischemia. So the chronic limb threatening ischemia too. Um, these people will have ischemia at rest, and then it might even lead to ulcers. So it might be minor tissue loss and then major tissue loss. So anytime you are seeing a patient with peripheral arterial disease, you need to, in your mind, decide, is this patient asymptomatic or is this patient symptomatic? And if the patient is symptomatic, is it then decide on the category. Is it mild? Is it moderate? Or is it severe? And then with the chronic limb threatening ischemia to you decide, is it the ischemia is addressed anyway, but is it coming with minor tissue loss or major tissue losses as well? So general approach to a patient with peripheral arterial disease is that then anytime you suspect, then you need to evaluate. So you evaluate with what we've already discussed, the clinical assessment, so taking history, looking at the risk factors and all. And then you look at the functional assessment. So you do the walking assessment. You can use the treadmill and even a questionnaire to assess them. And then after doing that, you need to now do the hemodynamic and vascular assessment to do an ABI. Um, um, and then you also follow this up with a duplex ultrasound and also do wound assessment if there's wound. Then you are now convinced that you have a diagnosis of peripheral artery disease, and also you've localized the lesion by using the appropriate imaging modality. So then you need to decide, is a person having symptoms, typical symptoms, or is a person having symptoms or not having symptoms? If the person is not having symptoms, it may be that this person is having maxed peripheral artery disease. So these are people you may consider doing stress tests for them to be sure. So it could be that it is maxed. And then once there are typical symptoms, you also need to know that is the person having, so you need to grade, is the person having ischemia at rest, and is the person having gangrene? So because that will also let you know whether a person is having chronic limb threatening ischemia. And then so it's either that one or the person is just symptomatic without any wound or any chronic limb threatening ischemia. Okay. So when you have done your assessment, you've categorized the patient into any using the scores to know whether patient is symptomatic, asymptomatic, or if the patient is symptomatic, is it limb threatening or is not. So after doing all of that, you need to now put everything together and decide on what will help the patient do optimal medical treatment. So with this, you need to address the cardiovascular risk and manage them, and also address lower limb related symptoms, improve quality of life generally. So things like stopping smoking, healthy diets, weight loss, supervised exercise training, then managing the with antihypertensive, anti-cholesterol, optimal glucose control, and antithrombotic therapies um, will be the next goal of treatment. Okay, so if the patient is not having wounds, you still need to still go through the same algorithm: asymptomatic, symptomatic, and then chronic limb-threatening ischemia. Then the goal is for all of them, you need to optimize their medical treatment. So for the symptomatic ones, you just must do their optimize their medical treatment, then you follow them up as well. For those with symptomatic peripheral artery disease, you need to you can go on to do supervised or structured home-based exercise training. Then this has been shown to improve the peripheral artery disease related symptoms. You can do vascular team assessments together with the other members of the team. And then you might also want to evaluate for revascular revascularization if it's indicated. But for people with chronic limb-threatening ischemia, you need to do optimal medical treatment, then vascular, and you need to also, because this is threatening, you need to contact the vascular team as soon as possible, and then consider revascularization if it's reasonable, and then if it's feasible. Okay, so um, in terms of the antiplatelet therapy for in terms of antiplatelet therapy for such patients, the you need to also decide as to whether you need to also decide as to whether the patient is having very high risk or low risk. So the general thing is I need to assess the risk level and then you follow up. So non-high risk limb presenting presentation or high risk comorbidities that you don't want to give other medications to cause additional issues. You may consider single antiplatelet therapy, aspirin or clopidogrel, and that's a class one indication. And for high risk limb presentation or high risk comorbidities without high bleeding risk. So those people, you can add reversible 2.5 milligram twice a day to the aspirin, and that's a class 2A indication. And for patients requiring long-term anticoagulation who already, maybe anticoagulation for something else not related to this, who are already on oral anticoagulant, then it will be safer to just leave them on the oral anticoagulants without adding antiplatelets, and that's a class 2 B indication. So to summarize, you'll be either be doing a single antiplatelet therapy based on your risk assessment, or you may be adding aspirin, or you may be adding rivaroxaban, or you may just continue the person's own rivaroxaban based on what's the person um based on the risk assessment. Okay. So for patients with chronic symptomatic peripheral artery disease, if you intervene after intervention, what do you do? So the long-term anticoagulation may be required based on the bleeding risk. If the bleeding risk is high, based on whether the bleeding risk is high or not. If so long-term anticoagulation, if it will be required and it's a yes, then you assess the bleeding risk. The bleeding risk is also high, then you can do monotherapy on oral anticoagulant. Then if there's no high bleeding risk, then you can do standard therapy 1 to 3 months on the antiplatelets, and then add oral anticoagulant. Okay, so for people with no who may not require long-term anticoagulation. Okay, so for those ones with no high bleeding risk and those with high bleeding risk, for those ones without high bleeding risk, you can do aspirin plus rivaroxaban 2.5 milligram twice a day because they don't have a lot of bleeding risk. And those with high bleeding risk can do dual antiplatelet therapy as well. Okay, so for whatever we just discussed, we are looking at the recommendations in terms of the recommendation class. So we use antiplatelet therapy with aspirin alone or clopidogrel alone, and it's recommended for reduction of major adverse cardiovascular outcomes in patients with some symptomatic peripheral artery disease, and that's a class 1 indication. And you can combine that with rivaroxaban, that's aspirin with rivaroxaban, should be considered for people with peripheral artery disease and high ischemic risk and non-bleeding risk, and that's a class 2A indication. So for treatment with combination of rivaroxaban and aspirin, should be considered for patients with peripheral artery disease and non-high bleeding risk following lower limb revascularization. So they don't have a lot of bleeding risk. And use of antiplatelet therapy with clopidogrel alone may be considered over aspirin to reduce myocardial infarction, stroke, and vascular death. So aspirin for primary prevention may be considered in patients with asymptomatic peripheral artery disease, DM, in the absence of contraindications. Okay. Then dual antiplatelet therapy for at least 1 year after revascularization may be considered to reduce limb events. And the long-term dual antiplatelet therapy in patients with peripheral artery disease is not recommended. And then oral anticoagulant monotherapy for peripheral artery disease, unless for another indication, is also not recommended. And the routine use of ticagrelor in patients with peripheral disease is not recommended. And it's not recommended to systematically treat patients with asymptomatic peripheral disease without any signs of clinically relevant atherosclerotic cardiovascular risk with antiplatelet drugs. Okay, so in patients, there's a recommendation for interventional treatment for asymptomatic and symptomatic patients with peripheral artery disease. So as to when there will be the need to intervene. In patients with symptomatic peripheral artery disease, after 3 months period of optimal medical treatment and exercise therapy, peripheral artery disease quality of life assessment is recommended. It is recommended to adapt the mode and type of revascularization option to anatomical lesion location, lesion morphology, and general patient condition. In patients with symptomatic peripheral artery disease and impaired peripheral artery disease-related quality of life after a 3-month period of optimal medical treatment and exercise therapy, revascularization may be considered. And that's a class 2B indication. In patients with peripheral artery disease, revascularization is not recommended if the reason is to solely prevent progression of the chronic limb-threatening ischemia. Okay, in patients with asymptomatic peripheral artery disease, revascularization is not asymptomatic revascularization is not recommended. So essentially, you would only revascularize for patients after doing optimal medical treatment and then exercising after 3 months, you are not achieving your goals. Okay. So the recommendation for interventional treatment of patients with symptomatic peripheral artery disease in femoral popliteal lesions, drug-eluting treatment should be considered as a first choice. In iliac lesions, balloon angioplasty with or without stenting in external iliac arteries or primary stenting in common iliac arteries should be considered. And all these are two-way indications. In femoropopliteal lesions, if revascularization is indicated, endovascular therapy should be considered. And in femoropopliteal lesions, if revascularization is indicated, an open surgical approach should be considered when an autologous vein is available in patients with low surgical risk. Okay. So what's the recommendation for management of chronic limb-threatening ischemia? And limb limb salvage in patients with chronic limb-threatening ischemia, revascularization is recommended after you've done yeah, so that one you don't have to wait compared to the others because already there's limb threatening ischemia. So it's a class 1 recommendation. And early recognition of chronic limb threatening ischemia and referral to the vascular team is also recommended. And in patients with chronic limb threatening ischemia, imaging of the entire affected limb should be considered so that you don't miss any lesions. Okay, and what is the recommendation for medical treatment in patients with chronic limb-threatening ischemia? It's recommended that patients with chronic limb-threatening ischemia are managed by a vascular team. And in patients with chronic limb-threatening ischemia and ulcers, offloading mechanical tissue stress is recommended to allow wound healing and is recommended to treat infections with antibiotics. Lower limb exercise training is not recommended in patients with chronic limb-threatening ischemia. So the exercise should be individualized, and for those with chronic limb-threatening ischemia, is a contraindication. Okay, recommendation for interventional treatment for chronic limb-threatening ischemia. In chronic limb-threatening ischemia patients, it is recommended to perform revascularization as soon as possible, and it is recommended to use autologous vein as a preferred conduit for infrainguinal bypass surgery. And in multi-level vascular disease, it is recommended to eliminate inflow obstructions when treating downstream lesions. An individual risk assessment weighing the patient's individual procedural risk for endovascular versus surgical revascularization by a multidisciplinary vascular team is recommended. In chronic limb-threatening ischemia, patients with good autologous vein and low surgical risk, less than 5% perioperative mortality, greater than 50% survival for more than 2 years. Infrainguinal bypass may be considered. That's a class 2B indication. And in patients with chronic limb-threatening ischemia, endovascular treatment may be considered as first-line therapy, especially in patients with increased surgical risk or inadequate autologous veins. So the last aspect is for people with acute limb ischemia. So acute limb ischemia is caused when there's an abrupt decrease in arterial limb perfusion, and it could happen as a result of progression of peripheral artery disease, or it could happen as a result of embolization, or when there's graft thrombosis, or aneurysm thrombosis, or popliteal artery entrapment syndrome, or trauma, phlegmasia, cerebral dolens, or egotism. And then hypercoagulable states are also risk factors, including iatrogenic complications as well. Okay, so in this case too, you need to grade the acute limb ischemia. So there's a grade to look at the viability as to whether it's viable, and even the threat, whether it's an irreversible threat or marginally threatened or immediate threatened. And in terms of the management for acute limb ischemia, so for acute limb ischemia, it's recommended that an urgent evaluation is performed by vascular clinicians with sufficient experience to assess limb viability and implement appropriate therapy. In cases of neurological deficits, urgent revascularization is recommended. Diagnostic imaging is recommended to guide treatment, provided it does not delay treatment, or if the need for primary amputation is obvious. In the absence of severe neurological deficits, revascularization is recommended within hours of initial imaging in a case-to-case decision, and treatment with analgesics is recommended as soon as possible for pain control, and these are all class 1 indications. It is recommended to monitor for compartment syndromes after revascularization and treat by doing fasciotomy. And it is recommended to assess clinical and hemodynamic success following revascularization. In patients with acute limb-threatening ischemia, patients with acute limb ischemia, it is recommended to obtain comprehensive medical history and determine the cause of the thrombosis, or whether it's thrombosis or embolism. And these are class 1 indication. However, it's a class 2A indication that in patients with acute limb ischemia following vascularization, if not on anticoagulation for other reasons, dual antiplatelet therapy um, um, can be started, or rivaroxaban and aspirin should be considered. Upon confirmation of acute limb ischemia diagnosis, treatments with heparin may be considered. Okay, so thank you. That brings us to the end of the presentation.
Thank you very much, Dr. Gordon, for this presentation. We are grateful for the time and the effort put in. Very excellent presentation. At this point, we open for questions and contributions. Kindly unmute and ask your questions. Thank you very much. Please, any questions or contributions?
Good evening, sir.
Good evening,
Thank
Mohammed.
you
Please go
very,
ahead.
thank you very much for the presentation. Sorry, I just wanted to get clarity in terms of when do we start the pharmacological treatment after diagnosis? Do we do the non-pharmacological treatment first, and then give a time interval as we do in hypertension when it's not above the markup limit of 1/1600 according to the new guideline? Do we start immediately, or do we give time and monitor with the non-pharmacological before we start the pharmacological treatment? So thank you.
Okay, thank you. So you do the non-pharmacological. Okay, first of all, when you make the diagnosis, you need to determine, is it asymptomatic, or is it symptomatic, or is it chronic limb-threatening ischemia? So if it's chronic limb-threatening ischemia, for instance, the focus is to do everything as fast as possible to get the revascularization done. And then if it is symptomatic, that one you need to decide on. It means you need to do the lifestyle all right, but you still need to do antiplatelet therapy. So as to whether you'll be doing just a single antiplatelet therapy, or you'd want to do the single antiplatelet therapy together with rivaroxaban, and that one will depend on the risk of bleeding as well. So if the risk of bleeding is not high, you can do those combinations. If the risk of bleeding is high, you can just do one. That is for the symptomatic. For the asymptomatic, there's a class 2B indication to start, not a class 1 indication. So it means that you can start, but you start these together with the lifestyle modification all at the same time. Please, is the question answered?
Yes, it is. Thank you very much.
Sorry, I didn't get what you were talking about, the blood pressure measurements. I heard 160. I don't know. I didn't hear something like that from the question.
Okay, so according to the new guideline, when a patient comes with a blood pressure of his blood pressure greater than or equal to 140 over 90, it's you don't start treatment immediately. You either send for ambulatory or home blood pressure measurement, and it's when you get a value above 135 over 85 that you ought to start pharmacological treatment. That first visit, what you just tell them after measuring the two different arms and then getting the um, postural um, BP, you now tell them to start lifestyle modification and then you give another appointment. But if you get an office blood pressure of 160 over 100 or greater, you are to initiate pharmacological treatment immediately. So I just wanted to find out if there was anything like that for the peripheral artery disease. And he clearly said that once you make the diagnosis, you start the treatment with the non-pharmacological treatment concurrently, depending on whether it's a critical limb ischemia or just peripheral artery disease.
Thank you so much. Thank you very much.
Thank you very much. So we have our consultant on the call, Dr. Ojo. And please, any contribution before we move to the next session of today's appointment?
Good evening, Dr. Eugene. Good evening, everybody. I came in late, but the little I met, I think it's a already well discussed topic, so I don't have any contribution from now. Thank you.
Thank you very much. Once again, I want to say thank you to Dr. Gordon for this wonderful presentation. Let's kindly show appreciation for this presentation. At this point, we'll continue with the second part, which will be the Viva, answering some of the Viva questions we are doing the 2022. I'll go off and join again after converting the presentation. Thank you.